Good evening, and thanks for joining me for this CME presentation on new and emerging biologic agents in chronic rhinosinusitis with nasal polyps, pathophysiologic insights, and patient selection criteria. This is provided by Integrity Continuing Education Incorporated, and as you can see here, it's an educational activity. It's supported by an educational grant by GlaxoSmithKline. I'm Dr. Michael Blaiss. I'm a clinical professor at the Medical College of Georgia and Augusta University in Augusta, Georgia. And these are my disclosures for this particular lecture. So we have three learning objectives that I hope to accomplish with you this evening related to chronic rhinosinusitis with nasal polyps. We'll review the pathophysiologic and immunologic molecular drivers of this condition, chronic rhinosinusitis, that lead to the inflammatory endotypes and relevant comorbidities frequently observed in patients with chronic rhinosinusitis with nasal polyps. And we'll discuss the differences between the currently approved and emerging biologic options for chronic rhinosinusitis with nasal polyps using data from clinical trials and other analysis. And lastly, we'll learn to incorporate an individualized patient-centric focus based on consensus criteria for patients with chronic rhinosinusitis with nasal polyps when recommending a biologic therapy or endoscopic sinus surgery. So we're going to start this evening with our pre-test polling. Here's our first question. Nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? Is it first A, interferon gamma, TNF alpha, B, IL-1, IL-6, C, IL-4, IL-5, IL-31, or D, IL-12, IL-17, IL-33. Make sure that you hit the submit button after you do your answer or it will not get counted. We can go to the next question. The immunologic nature of chronic rhinosinusitis with nasal polyps is typically characterized as type 2 inflammation driven by eosinophils. However, many patients with severe disease show which of the following? A, higher levels of Th1 and type 1 inflammation. B, more neutrophils and eosinophils. C, mixed levels of eosinophils and neutrophils. Or D, greater number of macrophages and CD8 positive T cells. Again, make sure once you answer to submit your answer. Hit the button at the bottom of the question, please. Well, let's go to the third one. So our third pretest question. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. And her blood eosinophil count is 302 cells per microliter with a total serum IgE of 25 international units. Which biologic would be the most appropriate? Is it A, Mepolizumab, B, Omalizumab, C, Reassess, D, Dupilumab? Answer now and then hit the submit button once you've answered the question. Okay. Let's go to the next pre-question. 49-year-old man with severe chronic rhinosinusitis with nasal polyps is placed on a biologic for his nasal polyps. Which should he first be reassessed for? When should he first be reassessed for? Response to treatment per either the EUFOREA guidelines or the multidisciplinary consensus algorithm. Is it A, anytime in the first 6 months, at 6 months, between 6 and 9 months, or any time after 1 year? Please answer and then submit your answer. Okay. And our last question for the pretest, a 53-year-old man with severe chronic rhinosinusitis with nasal polyps presents for follow-up after 12 months on biologic therapy. Prior to starting the biologic, he underwent endoscopic sinus surgery twice for his nasal polyps. They recurred within 6 months each time. He currently shows inadequate response to the biologic per the EUFOREA criteria and will not consider surgery again. What would be the most appropriate recommendation for this patient based on the EUFOREA guidelines? Switch to a different biologic, continue the biologic for another 3 months, and the last two answers, consider fluticasone intranasal spray, and D, stop the biologic, go back to medical management. Again, answer the question and submit your response for us. Okay, so that ends the pretest polling. So let's now start with an overview of chronic rhinosinusitis and chronic rhinosinusitis with nasal polyps. And I probably don't need to tell any of you that are on the CME program this evening that chronic rhinosinusitis is a high prevalent condition in the United States. In fact, almost 12% of the population has in fact had this condition. And in fact, if one looks at prevalence studies done from throughout the world, one will see this as a very common condition, not only in the United States, but again, in many other countries. And when we talk about chronic rhinosinusitis, we tend to divide it up into two major phenotypes, those with and without nasal polyps. The group without nasal polyps is the most common. It makes up about 80% of the total chronic rhinosinusitis population. It's primarily female. The group we're going to key on tonight, in fact, it's a group with nasal polyps. Again, that makes up about 20% of the total chronic rhinosinusitis population. And as you can see on the slide, it's primarily male. Now, what are the cardinal symptoms? And there are four major symptoms that we need to assess in every patient with the condition. And they include nasal obstruction and or congestion, nasal secretions, postnasal drip, loss of smell, which is extremely common in our group with nasal polyps, and facial pain and pressure. And if you look at the CT scan just below the cardinal symptoms, you can see here almost complete opacification of the paranasal sinuses in this patient with severe chronic rhinosinusitis with nasal polyps. And if you look over on the right, again, you can see the polyps here coming out below the inferior turbinate, and you can understand how that can lead to severe nasal blockage, and that can lead to significant problems breathing, especially at night. And these patients have been shown in numerous studies to have a very poor sleep quality. This leads to a great deal of problems during the day. We all know if we don't get a good night's sleep, how we feel the next day. And this leads to significant workplace decrease in productivity. We have increased absenteeism, but more importantly, we have presenteeism. So the patient is able to go to work, but again, because of the effect of poor sleep, they're just not as productive when they are at work. And these patients many times are embarrassed, they're mouth breathing, and they have a loss of confidence. Now, here is the diagnostic criteria. And we already mentioned the 4 cardinal symptoms, and patients have to have at least 2 of these for at least 12 weeks to be considered chronic rhinosinusitis, and they have to have 1 objective criteria at least, either endoscopy to in fact show that they've got drainage, mucosa edema, obviously nasal polyps, and or a CT scan to document the inflammation in the paranasal sinuses. So what is our standard of care? What do we start patients on that have chronic rhinosinusitis with nasal polyps? Well, we always start with an intranasal corticosteroid. And as we know, that is the first line treatment. Most of these, in fact, are over the counter at this time. There are some that are generic. And again, this is a topical agent. There's almost no systemic absorption. And as long as the patients spray it well, it's well tolerated. Sometimes we will see some nasal bleeding occurring with the use of the agent. Generally, we use twice the recommended dose that we give for patients with allergic rhinitis. And along with that, we typically use nasal saline irrigation. This can be very helpful for many of our patients. It reduces antigen load. It makes, in fact, the patients in many cases feel much better, helping to relieve some of the blockage. Generally, the studies show that only high volume use of saline, greater than 200 milliliters at a time, is much more effective than low volume. And there are some studies that suggest hypertonic saline may be the best choice here. Another option, though off-label, is there are none available in the United States, and that is nasal steroid irrigation. So some physicians may, in fact, do irrigation through devices like Waterpick or others with a steroid. Some may use like ampules of steroids like budesonide and have the patient drip them back into their sinuses. Again, there is no FDA approval at this time in the US for that. And then oral corticosteroids for rapid relief of severe blockage and to help as far as loss of smell. And what we typically call this is a medical polypectomy. In other words, a burst of oral corticosteroids will definitely quickly shrink the polyps. The problem is the side effects associated with oral corticosteroids that we're all familiar with. And what's been shown in asthma, and no doubt applies here for chronic rhinosinusitis with nasal polyps, is in fact frequent bursts of oral corticosteroids have an additive effect. So even though we may only be using them, say, for 3 to 5 days or maybe 7 days at a time, and not chronically, there is an additive effect the more and more of these bursts of steroids that you have. You can see here the short-term risk, but what really becomes a problem in these patients that require multiple doses is the long-term risk. We're all familiar with the increase in osteoporosis and cardiovascular disease. We can see psychiatric problems associated with steroid use, an increased risk of type 2 diabetes, cataracts, glaucoma, weight gain. So we really want to minimize the need for the use of oral corticosteroids in this patient population. So where do we go from there? Well, one is the use of surgery or devices. Endoscopic sinus surgery is minimally invasive surgery, though all surgery is surgery. And it has its risk associated with it, but it does get instantaneous relief of the blockage of the airway. But it does not cure the prevention of recurrence of nasal polyps. In fact, we had no treatment that in fact cures this condition. So it's important for patients after they have surgery to start back on their standard of care therapy, especially their intranasal corticosteroids. Another option in these patients that is approved by the FDA is the exhalational delivery system with fluticasone. So this is an intranasal steroid, but it's in a special type of device, which when one blows in it, it increases the pressure in the sinus cavity. So when one sprays the fluticasone, more gets to the posterior sinus cavity. And in their phase 3 studies, they showed that polyps were eliminated in 25% of the patients in one nostril or both nostrils by week 24, with only 8.7% with placebo, and that was statistically significant. And in patients who have had surgery, but in fact have reoccurrence of problems, there is the approved steroid-eluting implant stent. This can be done in the otolaryngologist office. It's placed in the ethmoid sinus. It is mometasone that is slowly released over 90 days. And in their phase 3 study, they showed a 61% reduction in the need for revision surgery. Now, so we talked about medical management surgery and polyps with polyp recurrence. So we have our standard of care, as you can see here in the arrow. And this study from Galen, which is the Global Allergy and Asthma European Network made up of numerous otolaryngology practices throughout Europe, showed that about 46% of patients failed standard of care therapy and in fact required surgery. Then there have been several studies to follow patients after surgery to look at recurrence. And in the first bullet here, looking at recurrence, this is a study out of the UK, showed that around a third of the patients had recurrence of their polyps at 6 months and 40% at 18 months. And then a large European study that followed patients after sinus surgery for 12 years found that about a third of the patients did require repeat surgery over that time period, with 20% requiring multiple surgeries. So then the question is, where do we go from there, or what other options? And that has led us now to understanding the inflammation and understanding the role of biologics. So let's now move on to inflammation and immunologic drivers and understand better the pathophysiology of chronic rhinosinusitis with nasal polyps. So here are the inflammatory endotypes, and we can divide these into, in fact, 3 groups. The most common associated with nasal polyps is, in fact, the type 2 that we're all very familiar with, related to asthma and atopic dermatitis, but also very important in chronic rhinosinusitis with nasal polyps. So the typical cells, the Th2 cell, the type 2 innate lymphocyte, eosinophils, mast cells, basophils, and the primary cytokines that drive this being IL-4, IL-5, and IL-13. So as I mentioned, nasal polyps, asthma, these patients have a high rate of loss of sense of smell, and we can see this even in patients without nasal polyps that have chronic rhinosinusitis. These patients tend to have minimal cough, pus, rhinorrhea. They don't usually complain of pain from their sinuses. Now, the next one is a non-type 2, formerly known as type 1, and this is driven primarily, as you can see here, by the NK cells and the Th1 cells and the cytokines that are important, interferon gamma and IL-12. And this is the most common cause that leads to chronic rhinosinusitis. These are the group that, in fact, do not have polyps. Type 1 disease does not usually lead to any type of polyp formation. And this, as we mentioned before, is more common in female than it is in males. And then we have the other non-type 2, which is type 3. And this one is primarily neutrophilic driven, primarily without nasal polyps, with the cytokines being IL-17, IL-22. Now, there is a group that does develop nasal polyps into this non-type 2 endotype, and that is the Asian population, where type 2 is almost exclusively the Caucasian and African American population as far as developing nasal polyps. So let's look at the immunogenic-driven inflammation in this condition. And we have to start with the epithelial barrier. And we're learning so much more about this and how active it is, and how especially changes here can definitely lead to the development of nasal polyps. So we know that in many of these patients, there are abnormalities of the epithelium. There can be loss or dysfunction of the tight junctions that bind the epithelial cells together. So that can make it easier for allergens and bacteria, antigens, viruses, and irritants to cross and activate the epithelium. Also, not uncommonly in our patients with chronic rhinosinusitis with nasal polyps, we'll see bacterial colonization with Staph aureus. We can see biofilm production and microbiome imbalance. The epithelium can release important factors that can also drive type 2 inflammation. These include TSLP, IL-25, and IL-33. As we know, we have the allergic pathway, and we can have those Th2 cells that are activated go through B cell isotype switching to produce IgE that is driven by IL-4 and IL-13. That affects the B cells to become stem cells and to produce IgE. In many of these patients, this IgE is directed against the Staph aureus superantigen. Now, that IgE then binds to mast cells and basophils throughout the body, but in fact, here we're talking about the sinuses. And then on re-exposure to whatever that allergen is, and say in this case, it's the Staph aureus superantigen, those mast cells will then explode, release hundreds of different chemical mediators. They lead to significant inflammation, histamine, leukotrienes, prostaglandins, and we also get a positive feedback production of IL-4. As we know, we can see high eosinophilic inflammation occur in the sinus tissue in our patients with this condition, and this is driven a great deal by IL-5. IL-5 is important in the bone marrow, leading to stem cells becoming eosinophils, and also is extremely important for safe circulation of eosinophils to the target organ. At the target organ, IL-4, IL-5, and IL-13 lead to upregulation of adhesion molecules. This leads to chemotaxis of the eosinophils into the sinuses. And very importantly here is the role of IL-13, because it has a major effect on the epithelium. On the epithelial cells themselves, it leads to increased mucus production and goblet cell hyperplasia. Very importantly, it leads to an epithelial mesenchymal transition. These cells, along with fibroblasts, lead to increased collagen production, fibrosis, and can add to a polyp formation. So we can see here that controlling type 2 inflammation in these patients can be very important as far as controlling their underlying condition. Now, a very interesting paper that was published last year in the Journal of Allergy and Clinical Immunology by Delamar showed a great deal of overlap between type 2 and non-type 2 disease. And I don't think any of us think that we think and know that we see this with a lot of conditions, that it's not black and white that the patient's type 2 or non-type 2, but there can be a lot of crossover here. And what they were able to show that in fact, especially in patients with severe disease, that's not uncommon, and that you see a mixed inflammatory pattern of not just eosinophils, but also neutrophils. And in fact, they showed that about half the patients without nasal polyps, in fact, have type 2 inflammation, and about a little over a quarter with chronic rhinosinusitis with nasal polyps, again, primarily the African American and Caucasian population, in fact, had mixed inflammatory pattern. So it's not black and white. And in fact, from their paper, there was this interesting diagram showing mixed inflammation in severe type 2 chronic rhinosinusitis with nasal polyps. And I'm not going to go through the whole thing with you, but over on the left, you can see the role we've talked about of the epithelial alarmins and the interleukins we mentioned, leading to eosinophils into the sinus tissue. And then over on the left, the role of neutrophilic activation and recruitment by things like IL-8 and IL-9. So again, it's very complicated here what's going on, especially in these severe patients. So with that, let's look at a couple of case studies. The first one here is Angela. So she was diagnosed with chronic rhinosinusitis with nasal polyps 2 years ago. She did undergo endoscopic sinus surgery 12 months ago, but unfortunately, her nasal polyps have returned. She did have allergy testing for inhalants. Those were all negative. And she was diagnosed with asthma at the age of 25. We can see she has a high total blood eosinophil count of 600 cells per microliter, a generally low IgE, and an FEV1 borderline at 70% of predicted. So she's had, unfortunately, limits as far as the medical management, the standard of care management for her condition. Again, she had endoscopic sinus surgery, but as we mentioned previously, unfortunately, reoccurrences do occur after surgery. So it's not uncommon for this to happen to this patient, Angela. In fact, when patients have more than one type 2 disease, so in this case, she's got chronic rhinosinusitis with nasal polyps, she's got asthma, those patients tend to have more severe disease of each of those conditions than if they just have one of those conditions. And so it's not surprising that, again, she failed surgical management. So she has, as we've talked about, she has type 2 disease. Now, Jason's a 50-year-old man. He was diagnosed with chronic rhinosinusitis with nasal polyps 4 years ago. He has had a history of perennial allergic rhinitis since childhood, positive skin test to dust mite, cat dander. He shows a total blood eosinophil count of 225. He has an IgE somewhat elevated at 150, and he has a borderline FEV1. He complains that the intranasal corticosteroids are not working as they did before. They're getting bigger. It's affecting his health-related quality of life. He doesn't like saline irrigation because of increased ear pressure. He's had 3 bursts of oral corticosteroids with antibiotics over the last 2 years. And he says he's willing to consider anything, I think all of us have seen patients like that, to get rid of their nasal polyps. And when we look about the limitations that he's had with his standard of care medication, again, the intranasal corticosteroids just haven't had enough absorption into the polyps to reduce the inflammation. He's had problems with saline irrigation related to ear pressure, and he's had multiple steroid bursts. And again, we have to be concerned about steroid side effects over the long term. So he has severe disease. It may be type 2 or more likely that mixed type that we talked about before with eosinophils and neutrophils. So with that, what other options are out there? And as mentioned, biologics. And so biologics, as we know, are immunogenic-based interventions help to turn off the inflammatory pathway that in this case is leading to their chronic rhinosinusitis with nasal polyps. So there are 3 biologics that have been approved by the FDA at this time for this condition. And we'll go in the order that they were approved by the FDA. First was Dupilumab, which we know targets IL-4 and IL-13. You can see the indication here, add-on maintenance for adults with uncontrolled chronic rhinosinusitis with nasal polyps. You can see the dosing is every 2 weeks. These are all subcutaneously given. There were 2 studies, Sinus 24 which was 24 weeks, Sinus 52, which was 52 weeks. And we'll go over the results of these phase 3 trials in just a second. The second drug approved by the FDA was Omalizumab. As we know, it blocks IgE. And you can see its indication almost identical by the FDA, add-on maintenance for adults with inadequate response to intranasal corticosteroids for nasal polyps. Now, its dosing is important here because it's based on the dosing for asthma, which takes in consideration the patient's serum IgE level, which has to be at least 30, and the patient's body weight. Now, they did 2 phase 3 trials, Polyp 1, Polyp 2, both were 26 weeks in duration. And the last agent that was approved by the FDA last July was Mepolizumab, which blocks IL-5. It has the same indication, as you can see here, word to word, as Omalizumab. It is given every 4 weeks, and we will look at the SYNAPSE study, which was a 52-week study that led to the approval of this particular biologic. So let's first start with Dupilumab. And it's important to note that there are 2 co-primary endpoints that are required by the FDA for approval of a drug for chronic rhinosinusitis with nasal polyps. One is nasal polyp score. So nasal polyp score is scored by the level of nasal polyps in each nostril, from 0 being no polyps in the nostril to 4 where polyps are coming out of past the inferior turbinate. And you score both sides, so the total highest score would be an 8. And in all of these studies, they have to have scores of at least 5 to participate in the study. So if we look here at it's Sinus 24, so if you look over at the left for nasal polyp score at the top A, here we're looking at the endpoint at 24 weeks, and you can see here that the nasal polyp score improved by 2 points. Remember, out of that 8-point scale, 46% of the patients with Dupilumab, 5% with placebo, and that in fact was statistically significant. And if we look over at Sinus 52, looking at the change from baseline in nasal polyps, again, we see a 46% of the patients with Dupilumab had a 2-point or better improvement versus only 1% with placebo. And again, this was a greatly statistically significant. And if we look at the bottom, the second co-primary endpoint is nasal congestion or obstruction. And the patient rates this from 0 to 3, 0 being no obstruction in the nose to 3 being I can't breathe through the nose. So it's a 3-point scale. And if we look here at the graphs for both Sinus 24 and Sinus 52, that there was significant improvement in nasal congestion score in both of the studies. Now, very importantly, to determine, in fact, if an agent is working here, does it decrease the need for oral corticosteroids? Does it decrease the need for surgery? So here we're looking at a cumulative effect. We're looking at both studies, Sinus 24, Sinus 52, a pooled analysis. And what you're seeing here is about 12.5% of the patients on Dupilumab either required surgery or burst of oral steroids during that 52-week period. It was 41.8% in the placebo. And as you can see, that was statistically significant. Now, what about side effects? And I think the good news is, in general, we've seen minimal side effects with the type 2 biologics at this time. And you can see here the most common adverse events seen with Dupilumab in this study were nasal pharyngitis and headaches. You'll notice a high rate in the placebo group of nasal polyps compared to the group on Dupilumab, again, worsening of their nasal polyps on placebo. Let's move to the second drug, and that is Omalizumab. And so we had 2 26-week studies here, Polyp 1 and Polyp 2. And again, they did the same co-primary endpoints, nasal polyp score and also nasal congestion score. Here we're looking at the nasal polyp score for both studies. And what you can see here at 24 weeks, which was the primary, where the primary endpoint was taken, there was significant decrease in nasal obstruction with Omalizumab in both of these studies. What about nasal congestion? And again, in both of these 26-week studies, there was significant improvement in nasal congestion at the 24-week endpoint. You can see the p-values here for both Polyp 1 and Polyp 2. Now, what about safety? I think all of us feel pretty comfortable with Omalizumab. It's been available for use in our patient population for greater than 17 years. You can see here the most common adverse event, in fact, was a worsening of asthma seen in the placebo group. That's not surprising. And then you see next most common nasal pharyngitis, backache. So again, we know that there's a very high safety record with Omalizumab in our patient population. Now, it leads us to the third biologic approved for this condition, and that is Mepolizumab. Now, this, again, taken from the paper published last year by Han et al. It looks a little different. What we're looking at here is more of a responder analysis. So over on the left, we're looking at change in baseline total endoscopic nasal polyp score. So they use the same score, again, 0 through 8. And what you can see here is the number of patients that had 2, 3, 4, 5 point improvement over the 52-week period. And that, in fact, was statistically significant. Now, they did do different for the nasal obstruction score. They used a visual analog scale from 0 to 10. And what we can see here again is the responder analysis. And you can see here 44.2% had a 5-point or greater improvement in that 10-point scale with Mepolizumab versus only 22.9% in the placebo group. So again, made statistical significance in nasal congestion score 2. Now, again, what about the reduced need for surgery, which again is upmost in our patient population? So we're looking over the 52-week period, and what you'll see here is the Mepolizumab group, it was about 9%. The placebo group was around 22%, and you can see here that it definitely was statistically significant in favor of Mepolizumab with a p-value of 0.0032. What about safety of Mepolizumab in this 52-week study? Well, again, a high safety rate, and you can see here the most common adverse events being nasal pharyngitis and headaches. Now, there are 2 other biologics that we're familiar with that are in clinical trials for chronic rhinosinusitis with nasal polyps. One is Benzorilimab that blocks the IL-5R alpha receptor. 2 studies, one that's been completed, but I'm not aware in the public domain that the data has been published as yet. And then we have Tezepelumab, which blocks TSLP. That study is looking at severe chronic rhinosinusitis with nasal polyps. We don't know the dosing at this time, but that is the dosing that you see there for asthma, and it's estimated to be finished in April of 2024. So we may have 2 additional biologics for this condition in the future. Also, all of these studies looked at many secondary outcomes, especially patient-reported outcome measures. And one of those that's most commonly used in these studies is the SNOT-22, which stands for the Sinonasal Outcome Test. And in the 22 questions, there are questions on quality of life and also symptomatology. And the good thing to know, in all three of the biologics that have been approved in the United States, all three showed at their endpoint to have significant improvement in the SNOT-22 compared to placebo. So let's move on now and talk about treatment selection. Now, there are many different algorithms that, in fact, have been published. This is one that was published last year by Johan et al., called the Multidisciplinary Management Algorithm for Chronic Rhinosinusitis with Nasal Polyps. Now, it states in a majority of patients, you start with sinus surgery. I could tell you that in my clinic, in those patients that fail standard of care therapy, we do offer the possibility of sinus surgery, but I also offer the possibility of a biologic, or in fact, the use of the exhalational device fluticasone, and with shared decision making that we'll talk about in a few minutes, let the patient decide. In this one, they start with sinus surgery and then go to standard of care therapy. And then it talks about that after sinus surgery, if in fact polyps redevelop, then it talks about biologics, revision sinus surgery. If they have AERD or aspirin or NSAID exacerbatory respiratory disease, then desensitization with aspirin could be done. We talked about a steroid sinus implant or just a short burst of oral steroids. And then again, reassessing the patient. And then they mentioned here the minority of patients, if it's a contraindication of surgery or they have very poorly controlled asthma or steroid-dependent asthma, or again, they just absolutely decline surgery, then those are patients to think about, again, the role also of a biologic. Now, how do we define if a patient has uncontrolled or severe chronic rhinosinusitis with nasal polyps? So this comes from EUFOREA, which is the European Forum for Research and Education in Allergy and Allergic Diseases. So this is made up of allergists, otolaryngologists, and others in the field of allergy in Europe. And they came up with these definitions. And I think they fit, or at least the uncontrolled fits, the two cases we talked about. So uncontrolled is persistent or reoccurring condition despite long-term intranasal corticosteroid and having at least one course of oral steroids in preceding 2 years and or previous sinus surgery. So both of our patients are definitely uncontrolled. Now, severe is bilateral, again, chronic rhinosinusitis nasal polyps with a nasal polyp score of at least 4 out of 8. Now, we haven't looked as far as measuring those two patients' polyps, but my guess from the history, they probably do have scores greater than 4 and persistent symptoms despite long-term use of intranasal corticosteroids and with the need for other add-on therapy. And then you can see the explanations under the slide. But again, I think both of our patients fit probably severe uncontrolled disease. Now, I mentioned shared decision making, so because I think this is so vital in this particular condition. And the American College of Allergy, Asthma, and Immunology and the American Rhinologic Society developed a shared decision-making tool, a decision tool, to help patients in determining what type of treatment they would prefer for their condition. Now, it's available on, as you can see here, the website of the American College of Allergy, Asthma, and Immunology, and it's really in two parts. One would be for the patients that are seeking care for nasal polyps for the first time, and the second would be for returning nasal polyp patients that have already had surgery, because there are some different options there. So it goes through in a language that the patient can understand. It goes through the pros, the cons, what the patient should expect, how the medications are administered, and also goes through cost. Then you'll notice on this slide it says your turn. And there are questions that the patient will answer to bring back to you that you can see their values. So if you see that first question there, I don't mind getting an injection every 2 to 4 weeks. Well, if they don't, they're an ideal candidate for a biologic. If they do, they're probably not an ideal candidate. If they do mind, they're probably not an ideal candidate for biologics. So, how do we select a biologic? And I think this is important. Predicting response in any individual patient is not yet possible. So I can't tell you in a particular patient which is the best biologic to use for them. We don't know the answer to that. So we want to confirm that they have uncontrolled severe disease. We want to check to see if they have any other type 2 comorbidities like asthma. So that would tell us if they have type 2 inflammation. Patients need to understand, again, the options, perspectives, and risk of all the treatments, including surgery. So that's the ideal for shared decision-making. And then if it's determined, then to select a biologic drug. And again, if the patient has asthma, there should be collaboration with an asthma specialist. So let's come back to Angela. 41, what additional tests, in fact, would you ask for? Really want to know how well her asthma is under control. And this may also tell us, because we know that these biologics also can be effective effective in the treatment of asthma. So we may be able to take care of 2 conditions with 1 treatment. So would you recommend revision surgery for this patient? Well, it's definitely an option, and we would have to discuss that with her with shared decision making. Might she be a good candidate for a biologic? Well, absolutely, because we do know she has asthma. We don't know from the history at this time how well controlled it is, but it does make sense in her to really think about the role of a biologic. And which one would I recommend? Well, all of them are excellent treatments, but because she has an IgE of 25, she really doesn't fit the nomogram for dosing of Omalizumab. So I would either go with Dupilumab or Mepolizumab. And again, she would need to know the dosing frequency, because that may make a difference. Dupilumab's every 2 weeks, Mepolizumab's every 4 weeks. Cost would definitely be an issue here. So that may, in fact, sway which biologic she goes to. So we need to give her clear information with shared decision making to know what in fact would be the best option for Angela. And what about Jason here with his perennial allergic rhinitis and again, severe nasal polyps? What other test? We'd want to make sure, in fact, he doesn't have asthma, since he had a borderline FEV1. Since he does have perennial allergic rhinitis, we definitely feel that, he's a type 2 patient. So he would definitely qualify in that regard for a biologic. He's never had surgery, so that's definitely an option for him. Again, but we want to give that as an option. And then we also have the option of biologic. So let's say he chooses surgery, that's fine, and then we see how he does. What if he says, I don't want surgery, I'd rather have a biologic? Then he would qualify for any of the 3 biologics that we mentioned this evening. Dupilumab, Omalizumab, and Mepolizumab. So let's say we start him on a biologic. Then, according to the EUFOREA guidelines, we reassess him at 6 months. And we're looking for improvement in at least 1 symptom by 6 months. So things like sense of smell, or congestion, or nasal polyp score, or SNOT-22. So if the answer is yes, and the improvement is acceptable to the patient, we continue that biologic. But if it's not acceptable, we may want to consider surgery at that time and continue the biologic, or maybe a burst of oral corticosteroids. But if the answer is no, he hasn't shown any improvement in 6 months, then it's time to either do a surgical procedure on him or switch to a different biologic. And then what do we expect at 12 months? Well, at 12 months, in fact, we should see really adequate control of all his symptomatology with no need for surgery or burst of oral corticosteroids. And if that's true, we continue him on the biologic, because remember, the biologic doesn't cure his condition either. It controls it. But if the answer is no, again, we might want to do surgery now. We may want to try a different biologic. So how do we differentiate these? Well, there are no head-to-head studies. So I cannot honestly tell you one of the biologics is more superior to another in a particular patient with chronic rhinosinusitis with nasal polyps. As I've already mentioned, they all have a somewhat different mechanism of action as far as where they block type 2 inflammation. But at this point in time, I can't tell you one is superior to the other. So in summary, understanding of the pathogenesis of chronic rhinosinusitis has continued to increase in recent years. I mean, I think it's been an explosion of information. And the introduction of biologics have really contributed to our understanding of the pathophysiology and management of this condition. And treatment of this condition should be based on the molecular drivers of inflammation. Very importantly, how well the patient responds to treatment. And I can't emphasize enough patient preference. And as we have these new and emerging treatments for this condition, hopefully the prevalence of recalcitrant condition of chronic rhinosinusitis with nasal polyps may diminish. Hopefully we'll be able to use less oral steroids and decrease the risk of side effects in our patient population. So with that, we want to now move on to our post-test questions. So here we go. Nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokine drivers? So your answers, please, and then submit by clicking the button at the bottom of the question. And so what we can see here now is that looks like 100% of you got the answer right, that nasal polyps, in fact, are driven by the type 2 cytokines, IL-4, IL-5, and IL-13. Next question. The immunogenic nature of chronic rhinosinusitis with nasal polyps is typically characterized as type 2 inflammation driven by eosinophils. However, many patients with severe disease show which of the following? So I'll let you go on and answer the question now. Well, the answer here, in fact, and we talked about that there's an overlap here in these severe patients, and they have a mixed level of eosinophils and neutrophils. So it still is primarily type 2 driven, but there is an element of neutrophils also, as we can see in the biopsy. So the answer, in fact, would be C, or the third answer there. Next question. A 39-year-old woman presents with nasal polyps and a history of moderate asthma. She has a blood eosinophil level of 302 cells per microliter and a serum IgE of 25 international units. Which biologic would be the most appropriate? Your answer, please. So we see a split here between Mepolizumab and Omalizumab. So what we have here with the total serum IgE being 25, she really doesn't fit the nomogram for the use of Omalizumab as defined by the FDA. She also has a high blood eosinophil level where we know IL-5 has a major effect. So I think the most of the four answers, the one that I would choose, and the correct answer here would be Mepolizumab, or the first answer. Next one. A 49-year-old man with severe chronic rhinosinusitis nasal polyps is placed on a biologic for his nasal polyps. When should he first be reassessed for response to treatment per either the EUFOREA guidelines or the multidisciplinary consensus algorithm? So we see here, in fact, looks like everyone that we have the correct answer now compared to the pre-test where it was 6 to 9 months. In fact, both of these say you really should see a response by 6 months. So at 6 months is in fact the correct answer. Next question. And here we have a 53-year-old male with severe chronic rhinosinusitis nasal polyps, presents for follow-up after 12 months on a biologic therapy. Prior to starting the biologics, he's had surgery twice for polyps that reoccurred within 6 months each time. He currently shows inadequate response to the biologic per the EUFOREA criteria and will not consider another surgery. What would be the most appropriate recommendation for this patient based on the EUFOREA guidelines? So if you can give me your answer. Okay, so in fact, it is the first answer. You would switch to a different biologic. And that ends our post-test polling. And we'll now move on to our Q&A session this evening. So if you'll type in your question, I'll be happy to try to address it. Well, I don't see any questions this evening. Well, I'll take that back. When oral steroid you choose, is it prednisone? Yes, I always choose prednisone or prednisolone. Either is correct. We want to use one that has the shortest half-life. So in fact, I usually give a burst of oral steroids being prednisone. Typically somewhere around 20 milligrams BID for 2 to 3 days, and then wean them over a 7 to 10 day period when they have nasal polyps. So that's what I typically do. There is no right or wrong dose, but I try to get them off the steroids within 10 days. How big a role should concentrations of Ig and eosinophils play in choosing a biologic? That's a very interesting question, because we do that for asthma. Again, we see that in the from the FDA as far as determining if a particular biologic qualifies for that asthmatic patient. But here with chronic rhinosinusitis and nasal polyps, you'll notice the indications on all three. There was no indication for serum Ig level or blood eosinophils. So whether they're important or not here, we just don't know the answer. I don't know of any data with nasal polyps that shows the higher the Ig or the higher the blood eosinophils, the more likely they're to respond to a particular biologic. So at least for this condition, I would rate them all being equal. And again, I would use shared decision-making, looking at dosing and cost as issues as far as determining which of the biologics I would choose for my patient with this condition. Great. Well, those were two great and important questions, so I appreciate those this evening. So with that, I think we will wrap it up. And for additional resources related to this topic, you can see the website here of integrityce.com/NP resources. And if you're on the platform, the webinar platform tonight, once this slide finishes, you'll be redirected to the evaluation to get your CME. Or if you're not on this platform, you can go to integrityce.com/chronic rhinosinusitis with nasal polyps. You can see here eval-2. So hopefully you found this informative this evening. Thanks for joining me, and good night.